you know what is just like amazing about the human psyche? It's pretty hard to take somebody's hope away. Like
Hmm.
we have a lot of protections that keep us hooked to the world we want to see.
Are you looking to leverage the latest and best ideas to grow your advisory business from the best minds in the industry? Join us every Wednesday at noon Pacific for our speaker series, featuring dynamic guests sharing real strategies for real results. Brought to you by the Best Notary, where we help estate planning attorneys grow their business with less stress and more success.
Welcome to another session of the Best Notary Speaker Series. Today's guest is Bridget Sumser. I hope I'm saying that right, Bridget. Did I say that right? Is it Sumser?
Perfect. Yeah, yeah.
Okay,
Sensor. Yeah.
excellent. And she'll be talking about a very interesting topic. I think that all of us can connect to in a very direct and visceral way. Beyond the documents, preparing surrogate decision makers and agents for end of life decisions. This series is all about connection and about highlighting trusted advisors in the professional services space. The host of today's event is the Best Notary, and here to introduce our speaker is Stephanie Rosso, PhD or COO, child psychologist and soon to be California licensed fiduciary. Before we begin, a few quick reminders. This presentation is being recorded. The second thing is you'll receive a copy of the slides after the session. Actually, I don't think we have slides for this session, so you will get a copy of the recording, which will also be available later on YouTube. Feel free to put questions in the chat during the session so that Bridget can reply to them during the session. I'll be monitoring, as Stephanie will mostly be talking to Bridget. And without further ado, I will hand things over to Stephanie to introduce Bridget.
Excellent. Thank you, Eli. So we are so excited to have Bridget with us. She's a licensed clinical social worker, a therapist, an educator, an author, and a nationally recognized leader in palliative serious illness and end-of-life care. She currently serves as the director of counseling and programs at Mental Health, where she helps individuals and families navigate the emotional, relational, and practical challenges that arise between a serious diagnosis and end-of-life care. With more than a decade of experience supporting patients, caregivers, and families through complex health journeys, Bridget has become a leading voice in advanced care planning, healthcare decision-making, grief, caregiving, and palliative care. Her work focuses on helping people navigate what she describes as healthcare's missing middle, the often overlooked space where individuals and families must make difficult decisions while balancing uncertainty, changing circumstances, and emotional stress. In addition to her leadership at Mental Health, Bridget maintains a private practice, providing therapy and coaching to adults, couples, families, and caregivers. Her work is grounded in a relational systems-based approach that recognizes the impact of healthcare systems, social structures, and personal values on decision-making and well-being. I could go on because she has so many accolades. But I'm going to take this time to, she's co-authored books and she's done so many things. And I am excited to have you with us today, Bridget, because every time you and I have had a conversation, I've been like, I want everyone to hear this. And so I am um, really excited for us to talk about um, how we navigate this. But I would love to know as we get started, how did you get into palliative care work? That's very specific.
It is so specific. Thank you for that warm introduction. And it's just amazing how hard it is to tolerate your own bio. Um, but really happy to be here with you all. And again, just to really reiterate that I think these topics are so alive. And they're alive for us in myriad ways in our personal lives, in our professional lives, in our social circles. So they really, in our own life, in our own relationship to our own bodies and our own health, which is just to say that they can be activating and we may end up with sort of questions and thinking about strategies that really kind of goes beyond professional context, because none of us are actually free from thinking about these things. So the invitation is really to be participatory and to bring your questions, because that's where the juice lives. I came to palliative care not knowing the language of palliative care. So really thinking about end-of-life care. And I came to end-of-life care through a series of experiences in my own life where people were ill and ultimately dying. And I kind of like looked around the room and everybody else was like real freaked out, and I was kind of okay. So I just started to get curious about that capacity, and honestly never expected to be specialized in this way at all. I kind of figured like death anxiety is a thing. I'll go learn about it and then just be more helpful to people across the life, the spectrum as a therapist, and then ended up very specialized and feel very honored to be hanging out in this space. So thank you for asking.
Yeah. So I think one of the things that struck me in our conversation was thinking about there are estate planning documents, or there are different kinds of documents.
Yeah.
And they're a great foundation. So I want to think about
Yeah.
what are in some of those documents and the different kinds of documents. So there are Advanced Healthcare Directives, there are POLSTs, there are DNRs. I think it's a good place for us to kind of ground in what are those,
Perfect.
and how do they help, and then also what more does one want to know?
Yeah, perfect. So the documents are really important, and quickly, right? An advanced healthcare directive, really the central reason we do advanced healthcare directives is to identify surrogate decision makers. This is a legal document that helps healthcare teams often, and then when someone has died, funeral planning, right? It helps in many settings, but healthcare directives help medical teams primarily understand who they should talk to if we ourselves are unable to speak on our own behalf. A POLST is a physician order for life-sustaining treatment. Outside of California, many states use something called a MOLST, or medical order for life-sustaining treatment. And these documents are more specific, act as medical orders. So they're more specific about the types of interventions a person may or may not want at the end of life. And importantly, in many instances, a POLST or a MOLST is the only way to have an out-of-hospital DNR order. So if you have decided that you do not want attempts at resuscitation at the end of your life, a POLST or a MOLST is often the only form that can stop emergency responders from responding in that way. It's actually why in California they're bright pink, is because they're noticeable. And this is the way that sort of conversations around about explicitly limiting interventions gets translated from clinic or hospital settings into community settings. An unfindable POLST is not a helpful document. It means it can't do anything if we don't know that it exists. And so that's why patients and families are often instructed to put them on the fridge, put them on the back of the door. You want them to be noticeable in the instance that something unexpected and emergent happens and emergency services ends up in someone's home. They're also super helpful documents when a patient is moving from facility to facility or from levels of care. So if someone's been in the hospital and had a series of goals of care conversations that end up in a do not resuscitate order, they would take a POLST with them to a skilled nursing facility, back to their assisted living, or back to home. So it sort of translates care decisions across environments. A DNR specifically is a medical order that generally lives in someone's medical record. And then, as I'm saying, sort of just to loop back, the POLST or the MOLST is the form that helps it translate outside of the healthcare system. So those are some of the main forms inside and around advanced healthcare planning. There's a lot of tools these days around how to get to the completion of those forms, like the conversation project, 5 wishes, different processes that sort of take patients or people living with illness through a series of questions, either to be done on their own, to be done with a professional supporter, or to be done with family and friends, a chosen family, to help get us to answers on some of the big questions: surrogate decision making, code status, artificial nutrition and hydration, and then generally style of care, so, or level of care. So send me the ICU, I want lots of intervention, treat what's treatable, but I don't want to spend time in an ICU, and or just like straight comfort focused care. That's a mouthful so far, but just sort of like orienting to like the space of the documents.
Thank you. I think that helps ground us. And so an advanced healthcare directive may say, do not extend my life, extend my life.
Yeah.
Right. It may say, I've seen some that say, provide pain medication even if it shortens my life.
Yeah.
Or it might say, keep me on life support for only 2 weeks.
Mm-hmm.
Right. So those feel like really important guides. And what I'm hearing you say is that that may not be enough information when it comes to the last weeks or months of someone's life to know exactly how do I interpret these things.
Yeah.
Yeah. So if we have that as the guideposts, what questions do we need to ask, and what more information do we need to know? If that's a great starting point, how do we start asking the questions, and what are the questions we need to ask from there?
Yeah. And I think I might not even think of the completion of documents as a starting point. I think something that's just so real is when we're thinking about advanced care planning, there's a major cultural assumption here, which is that we're interested in thinking about the future. We're interested, we're interested in anticipating things that may come.
Right.
And there's a reality where that is culturally incongruent for the way in which many people live. And universally, not universally, but I think it's fair to make some general, very sweeping generalizations. So like, again, this is not for all people. We have a pretty death denying and death fearing culture in general. And so regardless of sort of cultural identity, these are really hard conversations for a lot of people to begin.
Right.
And so that has really informed my stance around advanced care planning to be much more oriented around process than outcome. So it is great if forms are completed.
And only a third of people have an estate plan. So, right.
And that seems high to me, honestly. I think having spent, 15 years in a hospital, the number of people that I saw come in with completed advanced directives was probably 10 to 15%.
Wow.
And the other super humbling thing about that number is that people would come in, especially with sort of templated estate plan guides that just weren't particularly helpful, because guidance that says make sure I'm comfortable doesn't actually help us with, but does that mean the ICU if we think we can clear this infection? Because that might be uncomfortable for a bit of time, but then be able to restore you to some place of capacity and comfort. So these general orientations of do and don't are pretty tricky in a healthcare system that has a lot of nuanced intervention. So when I think about how I prioritize decisions and decision points in conversations about advanced care planning, I really think about surrogate decision maker, because that is a relevant question for 100% of us, because 100% of us are susceptible to unexpected illness and injury. And so that takes a little bit of the sting off. Like, I'm not asking you because you have advanced kidney disease. I'm asking you because being a human is a mortal experience and an uncertain mortal experience. And so it's helpful to know who we should talk to if we can't talk to you.
Right.
A lot of young people are like, oh, no, like it doesn't, I'm not old, it doesn't matter. But it's like, before I was married, I thought a lot about this because I have very contentiously divorced parents, and I had a boyfriend at the time, my now husband. And I was like, ooh, that's not a cute scene. The three of them at my bedside, two like parents that don't talk to each other, like really freaked out that their kid is ill or dying, and then a person who has no legal power but is the closest person to me. Like, it needs to be clear. And in many states there, and in California, this is true, there is no hierarchy of decision maker. So it is not
So
just,
who gets to make the decision then?
honestly, what happens if there is not the documentation in a lot of hospitals, the person who makes the decision is the person at the bedside.
Right. Whoever's just
Because
there.
what healthcare teams want to avoid is conserving people going to court. And so the reality is, if there is anyone we think knows this person well and is showing up in what seems like good faith, and there is not documentation, and we can't get more collateral about who this person said even verbally they would have wanted, we'll talk to whoever is there.
But to your point, if there's multiple people there and they're in conflict about this, and that someone says, well, she would want this, and someone else says, no, but that she wouldn't want that, but we've had this conversation, then what happens?
That's often when something like palliative care is consulted or bioethics is consulted, depending on how skilled the primary team is in mediating differing opinions.
Mm-hmm.
And we do our due diligence to contact, to make contact with anyone in the medical record that may have known the patient well. So a PCP or a oncologist, right? We're just looking for any sort of collateral to confirm the different stances that folks around the bedside might be having.
Mm-hmm.
But this is one of the biggest arguments for people to name
Right.
the surrogate decision maker, either because people are isolated, and so they really have to think hard about, is this a hired person? Is this a professional person? And or because we live in the setting of complex relationships, and so it's important to identify that person. The second part of that, though, is a surrogate decision maker who does not know that that is their job is not that helpful. In
Right.
fact, that is just a way to create enormous distress.
Mm-hmm.
So anytime I'm having a conversation with a patient or a client about surrogate decision maker, and someone says, yeah, it's my daughter, Jolene. I'm like, cool. Does Jolene know that? No. When was the last time you talked to her? 5 years ago.
Right.
Okay. So you're starting to get the feeling that this is like pretty real relational, psychological, social work.
Right. Or we've talked to Jolene, but we've never talked about.
Exactly. Oh yeah. More
Right.
commonly, Jolene's at my
Right.
house every day. She has no idea what I would want because we don't talk about this, or we never
Right.
have.
We've never had to talk about this. Why would we talk about this? And
I couldn't talk about, how could I talk to her about this? Right? Like that's too much for her. And it's like, but you're also saying that we should call her. So let's figure out how to support her in this job.
and it's so hard, I think, right? These end of life conversations are so hard in so many ways. And so I will speak from personal experience.
Yeah.
I had a mother with cancer who was at all at the same time fighting to live and preparing to die.
Yeah, totally.
And sometimes it feels like if I'm going to talk about dying, then people think, well, first of all, can they handle me talking about me possibly dying? Right. And if I talk about that, does that mean I say I've given up, and we're holding both. I am
Yes.
wanting and trying and planning to live.
Mm-hmm.
if I don't, we need to be able to have these conversations. And there's this both and at the
100%.
same time. So there's the like the abstract of someone who's in their 20s and like, oh, here's what I would want, right? But then there's the reality of, okay, I have a terminal diagnosis.
Mhm.
What does that mean?
Yeah.
How do I start to understand that? And how do I start to have those conversations that
Yeah.
I am living and dying at the same time?
Mhm. Yeah, it's such a beautiful, you're teeing us up for just some really beautiful conversation. And you're naming a tension that is the primary barrier for why healthcare providers don't facilitate these conversations more, because there's sort of dire worry about people not being ready
Mm,
and or taking hope away.
right.
And you know what is just like amazing about the human psyche? It's pretty hard to take somebody's hope away. Like,
Mm,
we have a lot of protections that keep us hooked to the world we want to see. It doesn't mean that big news can't really dent someone's hope, and that there aren't definite intersections in the experience of illness where what we are hoping for changes. But I try and remember, as a person sort of tasked with facilitating these conversations a lot, that I'm not important enough to take someone's hope away. There's just so much, there's such a sense of power here. Like, I could take their hope away. And it's like, well, the ethos that's sort of leading me is I never want them to feel alone
mm,
if their hope starts to wane, and or if they are currently or in the future worried about how things are going to go. And so it's more important for me that they know that they can come and talk to me about this, or that we can get into this stuff while holding the hope that treatment works, while holding the hope that we get better, while holding the hope that we've got 20 more years, not one more year, that we can do both things.
mm-hmm.
But we got to believe that personally, right? When we're in the position to facilitate these conversations for people, we have to get in touch with our capacity to sort of hold that dialectic, that binary, those two things at once.
Right.
It
And it's a lot to hold. And
is a lot to hold.
if
Yeah.
you're again, I'm speaking from, if you're the child of the person, right? How do I hold that in my own stuff, right? But I want to know. I want to have these conversations. I want to have these conversations and I want to avoid these conversations, right? I
Yeah.
need to know. Um, I need to know, and at some point, I might have to make decisions,
Mm-hmm.
right? That may be really difficult.
Yeah.
And so it's this coming in and going back and coming in and going back. And so
Yeah.
how do we start to have these conversations? How do we I think, normalize some of these conversations
Yeah.
before one is really ill? Um,
Mm-hmm.
and then when there is a potentially life-threatening illness, how do we start these conversations?
Yeah. I think so. I think, I'm assuming that most of the people here are in positions where you might be facilitating these conversations professionally. And I think that or you're related, you're sort of, you've got your spot in and around these conversations. And I think the hard but maybe also empowering truth is, like, we start these conversations by having them with ourselves as
Mm,
as professional helpers in our own lives,
mm-hmm,
really thinking about these things in nuanced ways. And there's tools for that. So this woman, Lisa Pauli, made these amazing decks, like the end of life deck, the death deck, and the dementia deck, which are sort of game-like conversation tools with prompts for thinking about what matters most to us. These are great entryways for starting to sort of test and tease and immerse ourselves in the topics. But it's much easier to facilitate an advanced care planning experience for someone if we've done it ourselves. And of course, it's different doing it yourself if you're 40 and healthy versus 50 and your mom just died versus 60 with your own chronic illnesses, right? Like all of the details of our lives contextualize what that experience is like for us. But the more familiar we are with the experience ourselves and sort of investigating the feelings that come up for us and answering the questions, the more empathetic we are, the more curious we are, and the more sort of comfortable and familiar we are, the more authentic we can feel, right? Not because we're lending, oh, I would never do that when we're working with a client necessarily, but because we just have some context for what it is to really sit with the reality of the uncertainty of our lives. So that's sort of one way that I think about starting, which is like our own comfort and our own familiarity in our own lives with these topics.
So we start with ourselves, because it's funny. I was talking with someone yesterday. I said this to you earlier, and she's like, I am worried about my mom having dementia. And when we're having a good time, I don't want to bring this up.
Yeah.
And if we're kind of having a stressful time, I don't want to bring this up. Right?
Totally.
So I like, there's no good time to bring this up. And partly I was saying normalizing it in some way.
Yeah.
We can talk about high blood pressure. We can talk about, knee stuff, but talking about worrying about dementia feels really scary, or right, like
Yeah.
talking about end of life feels really scary. But so I like these cards. They ask you some, and they're not all heavy, right?
No.
They're not all like, right? So
No, Lisa and I did a couple of weeks ago, we did a card together on a webinar, and it was like, what are 2 activities that are really important to me that I'd like to stay connected to, even if that connection means a very new version of it, right? I love to read. I love to be with people. I love to be in on the hot goss. I love to be out in my garden, right? Like, what are things that just feels so important to how I experience my life that I would want the people around me to try to help me stay connected to, right? Like that's not, I mean, that's not a particularly heavy conversation. That's like, oh my God, yes, I love when people spill the tea to me. I hope that they will continue to do that, even if they're unsure what I understand or how I may respond. Like I can imagine that would be really moralizing for me, that I'm not removed from this part of my life that I love so much.
Right. And these help answer things about quality of life.
Yes.
Right. If we're having to make decisions, what is my quality of life? And if I'm a surrogate decision maker, what is going to be important to them? Right. And like that helps me frame that. Oh, the garden is really important. The being able to have tea with friends, what is going to be meaningful and quality of life is part of this conversation, not just pull the plug, don't pull the plug.
100%. I mean, this is like the documents are really helpful. The documents don't give us any why. Why do not resuscitate? Why resuscitate, right? It doesn't fill in these sort of qualitative details around what informed these decisions. And that's a really meaningful gap, because there's a lot of things between, do I resuscitate or not? Do we attempt resuscitation or not? Is resuscitation
not a binary choice?
No, I mean, in some instances, but many of us will have experiences of illness where there's a lot more nuance in the choice. And just a directive, I would never want to live like this. I mean, I think the other thing that we haven't really gotten to say, and then Eli, I see your hand, but one of the things that's really tricky about anticipatory planning is that human beings tend to skew on either really overestimating positively or overestimating negatively, or over projecting negatively. And what I see a lot in advanced care planning is that people do not calculate for actually how adaptable we are.
Mm.
So I can say from here, in a healthy body, I would never want to live in a wheelchair or something, which people,
Mhm.
I mean, people say all sorts of
Sure.
things like, if I can't dance under the full moon in Thailand, life is not worth living. But then you end up with an MS diagnosis and your functional capacity changes a little bit over a long time.
Yeah.
And you actually realize that, like, being in a wheelchair in your living room with your grandkids around you is actually preferable to being dead.
Right.
It's a perspective you don't have before you've made a million micro adjustments and adaptations over years.
Mm-hmm. Mm-hmm.
Which is why the qualities, what makes a day worth living right now? You know, who do you want in the room making medical decisions with you? Who do you share the most important details of your life with? Who's close to you that it might be really hard to be honest with about what's happening in your life? These are the sort of like textures of a life conversation that start to open up how we might get to some decisions or answers, but ultimately also inform what's important.
Mm-hmm.
Eli, you have a question?
Yeah, thank you, Bridget. This is really powerful. I had never heard about the death deck. We'll definitely check that out. So broaching the conversation, very tricky. You guys just talked about that, right? Especially when maybe you are not necessarily ill. So I've been very fortunate to go to a few death cafes.
Yeah.
In Tiburon and a few other places, and been privy to a lot of profound conversations, right? I think usually interesting people go to a death cafe. So curious to hear whether you would suggest that as a forum or place where people can go kind of just to have a high level exploration. And then secondly, that's where I met Lori. Lori and I both volunteer for End of Life Choices California. And learned about reset, right, and all these other ways one can decide to take control of how they would want to transition, right? Sometimes when they're still healthy, as you said, right? So someone's bar could be from not having a level of satisfaction in life. I want to have my choices. And one gentleman at the Alameda Death Cafe said, I want to find a way to transition, even if I don't have a terminal condition per MAID. So the people plan trips to Switzerland and that whole journey. So I'm curious to hear your thoughts about those things. And I think, yeah, just for
Yeah.
those who are just like, I'm kind of done. I don't want to
Yeah,
transition.
totally. I mean, this is a huge world of discussion. I mean, any of these points we could talk for a lot of days to weeks about, there's so much in all of this. I think any space that is creating connection around mortality helps in these discussions, right? Whether it's just that we're building our own comfort with our own mortality and the mortality of the people that we are in relationship to, by love or otherwise, right? I think there's another whole layer of complication in this space that it's not uncommon for surrogate decision makers or supporters to be connected by obligation with very complicated texture to their relationships. Like we're not all loved ones in these spaces. But the more comfort and place we have to talk about our mortality, the more supple we are for these discussions. The one thing I will say about that I think, Stephanie, we may have talked about this in our prep call, but I have one mentor who says it's healthy people who like to talk about dying. That there's something about, I kind of like, I often use my arm like this for mortality awareness. And like when a diagnosis or an experience puts your mortality awareness like this, like it's actually really hard to talk. I can't see you very well. When we're healthy, we have a little bit more ability to really influence and control how much our mortality awareness is like coloring our everyday experience. And sometimes then it's like, oh, I can talk about how I'm dying because I really feel very capable and confident to put that awareness back here. And somebody who is living the experience of illness, it can be a lot more threatening because they feel just sort of less fluidity or less influence about knowing that they get to turn it off. So I just hold that lightly, that's not a judgment at all of healthy people who want to talk about mortality. We need this conversation to flow in our culture. We should all be talking about this as much as we can in ways that feel comfortable and life-giving to us. But I try and remember that when talking to ill people, the questions are differently threatening.
They have a reality to them, and it's no longer theoretical.
It's not hypothetical. It's
Yeah.
not like one day, right?
Right.
It's like, oh, I really am aware that I don't know when that one day is, and it could be really soon, or is going to be sooner than I would have ever wanted to. And sometimes what people really need in that space is to not think about it and to distract from. And I think that's another, maybe just like a good sort of softening reminder, which I think as professionals in this space, especially if we feel the weight, like we're caring for somebody who's getting sicker and they haven't had these discussions, it can feel like, oh my God, I need to get this to happen. Like if we don't decide to surrogate decision maker, if we don't talk about code status, like he's going to end up coded and blah, blah, that's going to be horrible. And so we can feel a lot of internal pressure to facilitate or make these conversations happen. That kind of angst doesn't usually help the conversations go well. And sometimes we really, not sometimes, we sort of always have to follow people's leads. We cannot sort of get them to go where they're not willing and able to go yet. And so it often means the like speed or pace of conversations around advanced care planning is slower than we would like, or more repetitive than we would like.
So Kirsten in the chat, it's this both, again,
perfect.
both and. Like, how do you broach the topic with a loved one about your own mortality when they're not ready? So sometimes we have, the child says to the parent, we need to talk about this, and the parent isn't ready. But sometimes the person themselves need to talk about it, but their loved ones aren't ready to talk about it.
Yeah.
I think both can be true. And
yeah.
How do we navigate that? What do we do?
Yeah. I think in either side of that scenario, it's really helpful to be bolstered by sort of clarity of what our relational ask is. So, my parents know that this is what I think and talk and do about most days. And oh my God, my conversations with them when I've tried to be like, okay, you guys, like, let's just talk, like, we got to talk about surrogate, like, you got 3 kids, you got boyfriends and girlfriends, like, who's doing what, where do you want me to be? Where do you want me to be situated in this? And they both had some version of like, oh, well, once I see signs of decline of any kind, there's not going to be decisions because I'm done here.
My mom would say, take me out and shoot me.
Yeah, exactly. Take me out back, right? I mean, this is like a very common sort of boomer response, which, sort of links to Eli's invitation to talk a little bit more about MAID. Those responses are super not helpful because it's basically just a way to shut down the conversation. Like, okay, I get that what you're showing me that we don't have a lot of tolerance for change in condition. I can hold that. And look, I know this is hard to talk about. And as your kid, I just really want to make sure that the order of who you want sort of in those discussions is clear. Because look, you know that me and your girlfriend, like, we don't get along very well. And so I'm happy to hang back. I just want to hear it from you. I want to hear it from you so that I'm not worried if I'm following my sense to hang back that I'm doing something wrong. You're helping me. And I think that a lot of times in the asks, the more we can be clear about like, I know this is uncomfortable for you and I need you, like, this is a solid you can do for me. I know you don't want to talk about how I'm sick and I'm really lonely over here thinking about it by myself. And so like, we can set a timer. Will you talk to me about it for 20 minutes?
So it's not going to go on forever. I can
Right.
prepare
It's
for
not going
that
to go
and
on
like,
forever. I don't think you can fix it. I'm not actually asking you to do anything. I just need to say that, God, I wish this cancer wasn't happening. And I really want to be here with you. And I'm starting to worry about the impact of this treatment. And I'm not sure. I'm just starting to feel in my own body that I'm not sure this is working. I just need to say that out loud. Right. But I think the pressure can build where we think we need to say everything at once. And the more we can practice these sort of like micro conversations and build trust with one another, that we can open it and close it and open it and close it and open it and close it.
right.
There's a lot of like psychic safety that comes from that. Just
Normalizing that process.
And we don't have to go from like
yeah.
A to Z in one conversation that everybody's just like wiped from.
Right. Kirsten said in chat that her mother asked her to give her a pill because she's a physician, and Kirsten was not ready for that. Like, I could understand as a daughter, like, I am not ready for you to tell me this.
Yeah.
That's heavy. That's a lot, right?
Yeah.
Moms have saying kind of like, help me out, I'm done. And as a daughter and a physician, right? That's a lot to hold. And
it's a
a
lot
lot
to hold. Yeah. It's
to
a
deal
lot
with.
to hold. And I don't know, I can imagine your physician mind. I mean, my, health social worker mind is, I'm like, Mom, there's no pill. That's not a thing, so there's also like that piece of like correcting the sort of, not taking the bait to correct the like misconception and try and resonate with the like, okay, she's trying to tell me something about her limits. And there is a real reality here around like getting super clear in our relationships about what is our right role. Is it my right role to be in primary discussion with my mom about this? Like, oh, for myriad reason, actually not. I'm going to hook her up, or I'm going to hook us up with professional person who can help hold these conversations with us. And I do think that that's often a structure that helps. And at Metal, that's something we see a lot, which is like, it's really hard to be the person to facilitate this conversation in a relationship, right? To be the daughter that brings it to mom, to be the mom that brings it to daughter, to be the spouse that brings it to spouse. And sometimes it is so, so nice to have a professional helper sitting on the other side, and me and mom, me and spouse, me and sister are on the same side of the bench, receiving questions together, receiving, like being facilitated through a process together, so that we get to be connected and sort of on the same team versus one of us is facilitating something for the other. And so when those dynamics get really loud, or it's just like, oh my God, I'm not I cannot ask my mother these questions. I cannot ask my child these questions. It's like, great, what awesome knowing. Let's get support in to ask you both the same questions together, or to ask mom the questions and help formulate a plan to give you. We don't have to do this alone. And we don't, like, if we come up against a limitation in ourselves or in the people in our lives, like, okay, that's just good information. Like, no judgment, no shame. I'm not in the position to respond.
Right. There's fiduciaries on the call who may be in this position of trying to figure out, helping people prepare for this, or like trying to figure out what someone would have wanted, and they don't know the person as well. I think that's also a really hard position to be in. And I appreciate that there are people like you and people at Metal who, like I'm pretty good with the tax stuff and the financial stuff and
Yeah.
maybe even the like getting to them to their appointments, but I really need some extra help in having these conversations
Yeah.
and
Yes.
helping to walk through this,
Yeah.
because
Definitely.
um, we can't expect someone to do everything, right? We can't expect to do this alone. We can't expect someone to do everything. So it's, I think, great to bring in experts and outside help, right? We
Yeah.
we
We
bring in
can't.
tax people to do the taxes, right? We bring
Yeah.
in,
Yeah. We can't
right?
be all things to all people. And the reality is like the pace and space and time that each individual person needs to get into the stuff of decision making or the stuff of care planning is really different. There's some personalities that can just be like, they show up in your office, they've thought about it a ton. They're by nature super direct and explicit and willing to kind of talk about things before they come, straight shooters. That's going to be very different than someone who has a more circular or emotional process, feels really isolated in the world, right? These are just different constitutions and different social locations. That means the support need is going to be different. It's a huge ask for you to be able to support the whole range.
Right.
And so being able to identify when more help is necessary is good, I think.
And it takes a huge personal, like, so you and I have been trained as therapists for decades. That still doesn't make it easy, right? But not everyone has
Totally.
that training. And then
Yes.
being a caregiver, that burden, that decision making, how do I do this? Like that is also gonna, especially for someone who's a fiduciary who has to do that a lot, like that can, I don't even know if it counts as vicarious trauma. But and there's not really a word for vicarious grief. Um, but
Yeah.
it's real, right?
Oh my God. Yeah. Yeah, I tend to think of it in terms of like intimacy. Like these are incredibly intimate discussions. And when they're formalized by way of processes and forms, we can get a little disconnected from how intimate they are and
Mhm.
therefore the impact on us in holding them. And I think there's a tremendous amount of grief for us as professional helpers. And I don't even like to think of it as like secondary or tertiary or traumatic. I'm just like, no, there's grief because we're interacting with the vulnerability of other people's lives
Mhm.
and the places in which we have intimacy, that we have influence, and then the places where we have no control and we're still watching it happen.
And we might want to avoid because it's hard. And we might
Yes.
like want to like retreat because I'm holding this alone.
Yeah.
For
Yes. I
many
mean, we
people, they're
need
holding it
this.
alone.
It's one of the beautiful things about this space that you all have created. And I think what we're hearing over and over and over again is that we all need more spaces to be in connection around what it is that we're seeing and confronting and holding in our work.
Mhm.
And the reality is that like for the rest of all of our lives, any service work is going to include this domain because of the aging population. School social workers, school counselors, like prison work, anybody in any sort of human service
Mhm.
is going to be dealing with this stuff.
Mhm.
Which on the one hand is sort of amazing because we don't have to like share professional background to really be able to share around the impact, and we'll have like interprofessionally more skills and tools to share with one another around how to meet the work.
Mhm.
Right.
um
About 10 minutes left, real quick, Bridget. I have a
yeah,
question from Lori.
yeah,
It's
great.
about the Right to Die documentary about Barbara Mancini. Could you chat about that? She says, what if you have your documents, but you might not be able to get what you want, right? Like this person, I guess, wanted to transition, got some morphine, and Barbara got in trouble for it. Could you talk about that?
Yeah, I haven't seen that documentary, so I can't speak to it in general, or specifically, but I think I think that's a real tension in this space. And the best sort of parallel I have to it, and I know not everyone on this call is a parent, and not every parent on this call is a birthing parent, but the best parallel is sort of the like phenomenon of birth plans, which is like, as birth plans sort of took a hold, it was like, I want the lights to be dim, and I want the music to be playing, and I want to be in a tub, not in a bed, and I want to be walking, I don't want an epidural. And right, we got super specific. There's lots of encouragement to get super specific about what you wanted to have happen. And then there's this like human reality that we're actually not in control of that process. Right. So it's good to know, oh, I'd prefer dim lights, but these are preferences at the end of the day, not dictating factors. And there's been a lot of distress, especially in and around medical aid and dying, around people feeling strongly about wanting access to those medicines and the ability to control and influence the moment they die. And in practicality, it's not a guaranteeable reality because things change. Cognition changes, capacity changes, certainty about what future days will look like change. And so we're less clear about when we push the date, we can't take the medicine, right? There's just a lot of uncertainty in these spaces. And so I think a fundamental capacity in all of this is getting comfortable with that, or at least getting honest about it, which is that we can be hyper clear and we can do all of the planning work and we still don't know how we're going to die. We still don't know what will transpire in that era. We could get a bad cancer diagnosis and do a ton of planning around how we want to die in and around that bad cancer, and then something else happens.
Right.
It's just so humbling.
Right.
Like,
Yeah.
it's so
And the
humbling.
reality,
Which is why we go back to the like stuff of, and maybe back to a point Stephanie made, which is you're a fiduciary and you end up being in the position of decision maker for someone you don't know well. And it's like, well, can we consider intake? Can we ask a quality of life question on intake? What makes up a good day?
Mm-hmm.
Just narrative. Tell me everything, anything and everything that can make up a good day for you. So that if you were 2 days later to end up called up for that person, you've got no contact with them, and you can be like, okay, they're people, their garden, being at home, the TV's always on. You've got some details that healthcare providers can help you put in context to what's happening and what is likely to happen.
Mm-hmm. And so let's say we have an estate plan that helps us in some ways. We've asked more information, and to your point, it's different if you have different kinds of diagnoses, right? There's different kinds of decisions
Totally.
at like if I have an MS diagnosis versus a cancer diagnosis, like, so we might have to revisit those questions again because now there's different kinds of things to consider.
Definitely.
Do we then need to, is that when we document that in a MOLST or a POLST? And is that a living, breathing document that we need to continue to revise?
I mean, my
is it
total
fine
bias,
to know in my mind?
yeah. My total bias, and this is, bias from like being a healthcare worker in a big acute care hospital for a long time, is that I don't really think MOLSTs or POLSTs are interesting unless you're limiting interventions. I don't care about a pulse that says do everything, because that's the system's default anyways. It's sort of, I guess it's sort of interesting that like someone's had a conversation and the choice was send me to the ICU and resuscitate me. But in terms of like when we really want to use those forms is because we've crossed some threshold where we're clear we want to limit the system's defaults. And the system's defaults in general will be towards life extension.
Right. To do everything, to keep you
alive.
alive.
And that is informed by a death denying and fearing culture, the purview of medicine to extend life, and honestly about liability.
Right.
Because
Absolutely.
not doing those things opens you up to a different kind of lawsuit than doing them and then withdrawing them.
Right.
If there's no written wishes, it's different if someone says, do not resuscitate me, and then we resuscitate you. That's a different sort of quagmire. But there's a lot of pressures to intervene unless it is very clear that a patient does not want that. And so POLST and MOLST is essential if it is clear that there's an intervention we're limiting. Otherwise,
You're
I
running
think,
out of time,
I
which
know.
is
Okay, the last thing I'll say
crazy.
is I think we haven't actually figured out the form to capture values and beliefs. We
Right.
don't have that document yet.
Right.
It is ripe for the making. If anybody's looking for a new business, like it's ripe for the making. What is the actual form that people can take with them, that they upload to their medical record, that's on their phone, that actually says, here's who you should talk to. Here's who else is important to me. This is what a good day is. Here are my religious beliefs.
Right.
That's a very real factor in this space.
Cultural and religious beliefs that we want to honor and respect, even if they might just be different than our own, right?
Yeah,
That
right.
we
Like
are to
culturally,
honor and
I'm
respect.
never gonna sign a form that signs away my rights or limits healthcare, and it would be so inappropriate for you to talk to anybody other than my oldest son. Right? Like this is the real stuff of people's lives. So we don't actually have the tool we need yet.
Right.
We
And I
have the
think that's
real
the
sort of
challenge.
crude, we have the real crude stuff
Right.
around do and don't do
Right.
that
Prolong
misses,
life, don't prolong life, which
and it
you
just
already
misses
said is
the
like,
stuff, misses so many of the decision-making points because medicine is so nuanced and
right.
capable now.
Right. Right.
We should do this again. There's so much to say. Are there burning questions we haven't answered?
I don't know.
We captured most of it. Real
It
quick,
certainly
Bridget.
seems like there's a ton more to talk about around medical aid in dying, voluntary stopping eating and drinking. How do we document those wishes? The utility in documenting those wishes related to how much capacity you have to actually enact any of those choices.
And in the reality, I mean, again, I keep talking about my mom, but she was like, okay, I'm going to rush this thing along. And I'm like, okay. And then I was like, well, you could stop eating. And she's like, all right, can I have chocolate cake? I'm like, you can have whatever you want. Right.
Stopping eating and drinking turns out is gnarly.
It's hard.
It's
right?
really hard.
It's really hard. It's
not comfortable.
It's not comfortable. And that's really hard. And so again, this push-pull of I want your last days to have some sort of meaning, have some sort of comfort, have something, and have you have control over that. And what does that mean? And so
and I think it's
thank you,
another, I
Bridget.
guess if I can, I'm just gonna like plug one more thing,
Please.
which is medical aid in dying is a good example of the fact that we care for people that will make choices we cannot imagine or we are ethically opposed to in some way. And that is one of the impacts morally of being in this space with people, which is that there are a million ways to live a life. There are a million ways to experience illness and to face a death. And we are often in the position to support people who are making radically different choices than we would. And how do we hold that?
Well, and then that's a whole other thing to hold. Like, I disagree. This is morally wrong. And and then having that respect of this is their life, this is their wish, this is how they want to do something. I may not fully understand it, but I honor their wishes and choice. And
potentially hitting a limit if morally, spiritually, religiously, medical aid in dying is not congruent to your moral compass, being clear that you can't help people in that space. Like, I think that's just that's just honest.
Right.
And I think we have to be tending to the places where we it's again, right relationship. Is
Right.
it my right relationship to support people in a choice that is religiously offensive to me? I don't know.
Right.
No, maybe I just need to be clear about who I can serve, who I can best serve.
Mhm.
Yeah.
And find
Also,
someone who can honor that.
Exactly. Have a good referral list.
So for everyone, you can see why Bridget and I, we could have these conversations. We
And
could
we
go
will
on
keep
and
having
on.
them.
We'll keep having them. Thank you, Bridget. Thank you for your wisdom and your thoughtfulness. And thank you all for joining us. Um, Please, as Eli said, join our YouTube channel. This will be up on YouTube after it gets processed. And if you want to have more of these conversations and you want us to have Bridget back, I would love to do that. And so hopefully this resonated with all of
Yeah,
you in some way. Because if you're not doing this professionally, you're also probably doing this personally, and then that has a whole other level of complication.
absolutely. And I just threw
So
my email in the chat in case anybody wants to talk more or wants to learn a little bit more about metal and how we might be able to help you. And yeah,
yeah,
thank
thank you,
you all
Bridget.
so much. Yeah, what
We'll
fun.
also be sure to include that in the post-event email, link
Great.
to your site and all that good stuff.
Please. Okay.
Thanks everyone for
Thanks,
being here.
everybody. Yep.
thank you,
See you.
everyone.
Bye.
Come join us on Zoom every Wednesday of the month at noon Pacific and 3 p.m. Eastern. Please don't forget to subscribe to our YouTube channel to get notified when new episodes are released. This speaker series is sponsored by The Best Notary, your trusted document concierge from Maui to Maine.